Hello, my name is Lynn Crawford. I'm with the Hope Dementia Support Groups, and we're here to present a webinar regarding hospice and palliative care when your loved one has dementia. We are very fortunate to have a panel of hospice and palliative care experts here, and they will each be speaking in turn to tell you a little bit about hospice and palliative care, and then you'll have time for your questions that you can be typing into the Q&A box at the bottom. Thank you all very much for being here. I'm going to introduce Julie Wheaton to start with. Julie is a nurse practitioner for palliative care for Peace Health.
Hi, thank you, Lynn. Like Lynn said, I am a nurse practitioner with Peace Health Medical Center in Vancouver, Washington, with the inpatient palliative care team. And I'm just going to talk to you a little bit about what palliative care is specifically and how that is different from the inpatient setting to the outpatient setting. Generally, when I meet with an individual and their family, you know, we're meeting in the inpatient setting in more of a crisis mode, and an outpatient setting at the either beginning of a illness diagnosis or as things are starting to change. And so when I meet with people, I like to talk to them about a little bit about what palliative care does and what we can offer them kind of as they're going through these transitional processes. So palliative care is a supportive program for individuals and their families as they deal with a chronic life-limiting illness. There are a couple different functions that palliative care can serve. The first is to act as an extra layer of support for that individual and for their family as they're continuing to go through treatments, continuing to follow up with their primary care as well as their specialists. We don't stop any treatments. We act as an extra layer of support while they continue to move through those. Within those treatments and the disease process, you know, this can be heart failure, COPD, liver or kidney failure, cancer, dementia. We spend a lot of time working with the individual and with their family members on education about that illness or disease process, what the expected trajectory is of that process, what we expect to see in the near future, what we expect to see in the long-term future as far as symptoms, and general experiences that most people have when they're dealing with that type of illness. And we want to educate, you know, the family and the individual about what that looks like in the setting of anything else that's going on in their health. Within that education, we talk a lot about symptom management, and this goes hand in hand with working with the individual's primary care team and with their specialist team. Oftentimes there are symptoms that need to be managed on a higher, more specific level. Oftentimes this includes pain, nausea, and vomiting, and it can be somewhat general, but also, you know, in the case of a cancer patient, very specific to what's happening with their treatments. And so we can work closely with their specialists, with that individual on not only talking about what symptoms to expect, but making sure that those are well managed, whether that's through medications or other non-pharmacological interventions. Another aspect of palliative care that's really important is talking about goals of care. It's really important to remind individuals and their families that not every recommended treatment is something that you're required to go through, and that you have a right to understand what those treatments mean for you and how they can affect you. What those treatments look like in the short term and in the long term, and discussing what that means for each individual and if that aligns with what they want for their own personal care. We talk a lot about likes, we talk a lot about dislikes, we talk about good and bad quality days and what makes good quality life. With all of that put together, we do also talk a little bit about end-of-life decisions, because at the end of every life-limiting illness, it is time to prepare for end-of-life decisions, such as, is hospice appropriate? Is that a far out issue? Is that a nearing issue? We talk about each individual's line in the sand, what they consider a good quality life, a tolerable life, and at what point they would want to shift their care from focusing on continued treatments to focusing on comfort. Palliative care gets divided into two different arenas. We have the inpatient palliative care in the hospital setting when most families and individuals are in a crisis of some sort, bringing them to the hospital. And so a lot of times we focus really heavily on what are your immediate goals of care, what is the new change that has brought you to the hospital, what are some of the symptoms that are causing issues right this second, and the treatments that are being offered, so that we can identify if these options are something that align with your goals and with your family's goals, or if we need to move in a different direction. In the outpatient setting, it can be more program specific. Again, the goals really are focusing on your goals of care, things you want, things you don't want. I'm talking a lot about disease education, understanding the illness, understanding what to expect out of it, and understanding not only how it affects the individual, but also affects their families, and having recurrent goals of care. Oftentimes in inpatient and outpatient, we deal with symptom management, where symptom management in inpatient may be oftentimes more pain focused. In outpatient, it could be, an entire constellation of symptoms that the patient might be experiencing. So Peace Health specifically has both an inpatient and outpatient program. The outpatient program is a little bit different. We have the ability to have nurses and social workers that can see a patient in the home setting. Currently, unfortunately, there's a wait list for that. But in a few months, we will also have an outpatient clinic where you can see a palliative care physician or nurse practitioner as well. I know within our community of Vancouver, we also have an outpatient clinic at the Vancouver Clinic where patients can be seen with their families, and there's an outpatient clinic at Legacy. And again, they would all continue the same outpatient plan of, ongoing goals of care discussion, discussing symptoms that are, problematic and that need additional attention, always end-of-life decisions, talking about emergent things like a pulse form, where we talk about, would we want to have CPR? Would we want to have intubation with a breathing tube? Talking about longer things like feeding tubes, and eventual, illness-specific treatments, and whether or not they truly align with that individual's goals. So that is a general summary of what palliative care has to offer.
Thanks, Jennifer. So next we have Dr. Michael Balbuena, who works with the Providence Elder Place. And I'll leave it to you, Michael, to talk about what it is that you do.
Thank you, Lynn. Also, thank you for attending. I know it's tough and after a day to decide to get online and look at a picture of someone talking to one. So I do work in Oregon, so I'm a little bit less accessible than our other three panelists. I work with a program called Providence Elder Place. It is a program for all-inclusive care of the elderly, which is a mouthful, so we tend to just call it PACE, P-A-C-E. There was a group that was looking at starting a PACE program in Vancouver several years ago, but I don't think it ever got off the ground. PACE program has laws and regulations that dictated by the CMS, which is the Committee for Medicare and Medicaid. And so they basically tell us how we can function within the community. Our participants need to be at least 55 years and older and in danger of losing their community placement. So what that means is that for whatever their medical or psychological illnesses are, it's looking like they're going to have to be moved into a skilled nursing facility in order to stay outside of hospitals. Our goal is to try to keep them out of the skilled nursing facilities and in either a residential care facility, in their own home, or in a family home. Some of the things in Oregon that we have a lot of are adult care homes as well. which function really well for some of our older people with dementia. The Elder Place itself has about 1,000 to 1,100 participants at any time. Most of our people will stay with us through the end of life. So we don't access hospice per se. We tend to do our own in-house end-of-life care. I am trained through OHSU as a palliative care physician. Many of the other providers also have either geriatrics or palliative care specialties that they're certified in. So we have a palliative care program, which Julie summarized palliative care really well as far as the different aspects of it and what we try to keep on top of. So most of the people who join Elder Place will start not on a palliative care program. Some do. I actually accepted one person who he died within a few weeks of joining me, and it felt more like what hospice unfortunately experiences a good deal of the time. But most of our participants will join us not on a palliative care program, and we just manage their medical problems and try to maintain their independence as much as we can. As they decline, we then start talking to the participants and their families about end of life, goals of care, and our palliative care program. Ours has a 3-tiered system to it. The first tier for me tends to be more of a psychological shift, where you're going from sort of wanting to do long care that will increase your length of life to care that will increase your quality of life and comfort, more of the palliative care program. There aren't any changes that usually occur at that time when you go to palliative care 1. For me, it's the sort of rule of thumb would be, I wouldn't be surprised if you were to die within a year. If I look at a participant and their medical situation and their rate of decline, and it feels as though it wouldn't be a shocker if they were to die within that year, usually I'll approach the family, and a lot of times they too will have been noticing the decline. The nice thing about Elder Place is we tend to really involve family as much as we can in the process. I know when I worked at the Vancouver clinic, it was usually just the one participant or the patient that I was dealing with, and I didn't really have much contact with family. With Elder Place, you're sort of guaranteed to be dealing with family members as well. As they decline, then we think about palliative care 2, which equates more to a hospice level of qualification. And the rule of thumb there is I wouldn't be surprised if the person were to die within 6 months. Now, as with hospice, that doesn't mean it's a guaranteed you have to die within 6 months, but just that if it were to happen, it wouldn't be surprising. And palliative care 3 for Elder Place is actively dying. So we tend to try to have these conversations well in advance, at least to introduce the idea. And that's where the palliative care 1 is useful because, again, it's not a shift in care or medications or level of how often we're going to send someone to the hospital. It's more of just an acceptance of the fact that the person has a terminal illness and that we anticipate that creating some issues in the future. Most of the participants who join Elder Place have some form of dementia. It's about a 65 to 75% of the patients have dementia. And so we tend to be working with families a lot in that case as the person's ability to make decisions for themselves declines. We have a nice wraparound program. We include a lot of extra things besides just the end-of-life care. And it would be great if at some point in time, Vancouver and Clark County were to get a PACE program for themselves. Jennifer, off to you.
Hi, my name is Jennifer O'Donnell. I'm a nurse practitioner with Peace Health Southwest Hospice. I'm a relatively new hospice provider. So I'm going to share more kind of my insights of how hospice works more, maybe more in a personal way, but dementia is close to my heart. I have, we lost our father-in-law I lost my father-in-law to dementia several years ago. And then my father had a fall about 3 years ago and had suffered a few brain bleeds. So he lost some of his cognitive ability too. And so of course it's very close to my heart. And I know it touches so many people's lives and it's so important. And I feel like hospice is just it's a great program. No matter what program you join, if it's Peace House or community, they're all great. And the most important thing I think about hospice is that it's really a team approach, and it takes in the patient, their family, and whatever that patient considers family, whether it be a wife, a spouse, a significant other, an important neighbor. It really takes into account everybody. It's a team healthcare system. So not only do you have the patient and their family and their provider, but you have nurses and caregivers, social workers, chaplains, and a lot of people behind the scenes that work with each of the families, each of the patients and the families. Another thing about hospice that's important to me and what I really love is that the patient really makes a decision. The patient and their family makes a decision what they want. It happens, of course, as we have heard, later, closer to the end of life, typically within about 6 months of life. And so we really focus on what's important to the patient. Sometimes what's important to them is an event, or like a wedding or a graduation or something. And so we make sure that we spend time with that patient, and we fulfill, like Julie said, their goals of care. And their goals of care is, of course, based on what they want and what their family wants. My job as a provider is really, it's kind of simple. It's in a nutshell is I'm there to make the patient comfortable. And my goal is based on what the patient actually wants. So it could mean reducing the amount of medications they take. It might mean adding some medications, but it's all done as a group effort. So I think that's kind of the gist of hospice care. And I think there's a lot of people, I know there's a lot of people on hospice with dementia, and it's just a great way for the patient and their families to be able to work together with a whole team of providers. And some days you might need a nurse, and other days you just might need a chaplain. So I think there's a lot of different avenues too. So that's kind of my take on hospice. Thanks for letting me talk.
Thank you, Jennifer. And I apologize to Julie. You know, I've got too many J's and I'm old, so I get confused easy. So fortunately, I'm going to introduce Denny now, who is a medical social worker from Community Home Health and Hospice.
Hello, everyone. Thank you for having us tonight, and thank you, Lynn. I am a social worker, like Lynn mentioned, with Community Home Health and Hospice, and my specific role is to be a home hospice social worker. And in my role as a social worker on the hospice team, I focus a lot on family members and how their loved one's illness and decline is impacting them in all kinds of ways in life, financial resources, stress, anxiety, just getting the household in order, or any type of other miscellaneous thing that may be stressing them in addition to the illness and the personal care. And that's my role as a social worker. So whenever I go to a home of one of our patients, I always check in with the caregiver and see how the caregiver is holding up, if you will, under the stress of all of this, and just see if there's anything I can do or any resource that I can gather or connect for them that eases the journey, I guess, a little bit. Community Home Health and Hospice is a private nonprofit agency that has home care as well as home health and hospice. I thought, I'm hoping you'll indulge me a little bit if I just kind of tell you about my career path. Way back in the mid 80s, when I was an undergraduate, I was real interested in human development, and I took a class in adult development and aging. And about that same time, my mom was taking care of my grandpa, her father, who had Alzheimer's. And it was just so impactful to me to watch the love and compassion and the devotion and sacrifice that my mom made in her life to take care of him. And he was home in her home with her. And she just took care of him every day. And even today, after all these years, she talks about how, you know, right there towards the end, she had to put him in a nursing home, and she feels bad about that still today. She's 85 now herself. But anyway, so that piqued my interest in that business. I went on to get a master's degree where I specialized in geriatric social work. And after that, I ended up working in assisted living and retirement living, and eventually had a 25-year career as an administrator in assisted living facilities. And then about 6 years ago, I just decided I didn't want to do management anymore. And I just wanted to kind of finish out my career working directly with families and patients and individuals. And I love doing that in the home setting. And so, like Jennifer mentioned, that's one thing I really love, in addition to the team approach that she mentioned, is actually going into people's homes is a wonderful thing. Anyway, like she mentioned, hospice is that thing that nobody really wants to talk about. In fact, it's not unusual when we get a referral and we talk to the family, they say, now don't use the H word. You know, we don't want to use the H word here. And we say, okay, we understand that, you know, so we'll just come in and say that we're home care workers, and, you know, we're just here to help out providing medical care at home, kind of, or something like that. And that's fine with us. We understand that. But hospice is when a person is ready to just not call 911 and not go back to the hospital, and just be home and just be comfortable, and have the services and care brought to them at home is pretty much the best way to describe that. Hospice does require a referral from a doctor, and it requires actually 2 doctors to complete for Medicare what is called a certificate of terminal illness, which is basically just saying that the best guess is, or like Dr. Valbuena said very well, you know, would not be surprised if this person's end of life was within 6 months. Hospice is a Medicare benefit, and there's no copays, no deductibles for it. It's an entitlement in Part A of Medicare. And almost all the private insurances cover hospice services as well. And in fact, most of them model their hospice benefit after Medicare's hospice benefit. So we get the referral, and then we go to the home and provide an explanation for, you know, what hospice is about. And Jennifer mentioned the team that's involved, and I love that part of it too. I do want to tell a little story. A lot of people, I know there's a feeling out there that, you know, hospice is for imminently end of life. And the reality is that nobody really has a crystal ball about how long a person's going to live. And so, but, you know, best guess of 6 months. And I remember, some time ago, I had a patient and I went to their home for the first time to do the initial admission visit. And they said, he and his daughter said, well, you know, we came home from the hospital and we're told we have probably had about a week, you know, to live. And so we brought in the hospital bed and all the necessary equipment, which is another thing that hospice does provide. And ended up having that patient for 3.5 years. So, you know, you just can't always tell exactly how long somebody is going to live. So the 6-month thing is something that Medicare provides so that there's some parameters around the hospice benefit and who receives that hospice benefit and who doesn't, more really than it is, you know, any sort of telling how long somebody's going to live per se. So, and then the way the hospice benefit works is after the first 3 months, then the person, if the person is, or the patient is still declining, then they can be recertified for another 3 months. And if they're still meeting the qualifications for hospice, then they get recertified for another 2 months and then another 2 months and so forth. So that's kind of how Medicare likes to provide some parameters to the hospice benefit. So in addition to providing the team, we also provide medications, durable medical equipment, supplies. And the idea behind this from Medicare's point of view is that hospice then becomes responsible for providing all of these things to the person and the family to ease their burden and to increase their comfort and quality of life for however many days the natural course of their illness takes. So that's the idea behind that. I guess one other thing I just wanted to say is that a lot of people worry that once a person is admitted to hospice care, that hospice will remove all of their medications, and that's not really entirely true. What actually happens is when we get a new patient, we sit down together as a team and we review the recent history and comorbidities and all of the medical picture and history, including, like Jennifer said, the patient's goals and the family's goals and desires. And then we make recommendations for, you know, what would be best for that. You know, some things would be best to be kept and other things might be harmful as the body organs and systems shut down. So we come back to the patient and family and make recommendations about that. And then together we decide what to keep and what not to keep. So that's actually how that system works. Finally, I just wanted to say that as a social worker, I feel very strongly that this whole thing of having dementia is a journey, and every journey has slightly different paths. And I feel very strongly that this journey is just as much a psychological, emotional, and spiritual journey as it is a physiological and a medical one. And so we are always alert and attentive to all those elements of this journey. And I love doing this. I just feel like any little thing I can do to ease the burden or smooth the path a little bit for somebody is a joy to me, and I love doing it. So thank you for having me.
Thank you, Denny. So if everybody would turn your cameras on, we have questions that you all can feel free to answer based on whatever. And my first question, someone asks, I think someone said dementia patients can receive palliative care. when does that usually start?
I'll chime in here. So the tricky part with that is, and the hospice folks might correct me on this, I don't believe dementia is a qualifying diagnosis for hospice anymore. So we have to separate hospice from palliative care in this case. And so palliative care is looking at just trying to ease the suffering from the diseases that these people have. So palliative care can happen at any time that there's a symptom or a problem that needs to be treated in a way that's not really focused at trying to cure a problem. Now, for the PACE program, many of our people will be on our program with dementia and not be on our palliative care program for a while until they start to decline. There's a FAST scale, F-A-S-T, which can look at the decline in function for people with dementia, and it's a 7-layer scale. And usually you get to a FAST score of 7. 6 and 7 is when you start thinking the person's getting towards the end of their life. But because dementia is such a prognostically very hard to predict how long someone will last with it, you can be at that 6 and 7 level for months to years. And so unless you're showing a steady decline, the rules that hospice works under by CMS, you end up graduating, which sometimes is sort of silly to say, because it's not like someone with dementia at that level is going to suddenly rebound, but they're not continuing to decline in such a way that they can stay on. It's tricky. So there isn't a great, when the person's at this level. You really, for palliative care, if there's a problem that needs to be addressed through a palliative care program, that can be done. Through hospice, it's a little trickier.
Does insurance pay for palliative care?
I can only answer for Elder Place, and for that, it's part of our included program. So when you join the program, you get a whole bunch of stuff all in one package deal, and end-of-life care and palliative care is included in it. So for us, yes. I don't know if palliative care.
Julie, can you talk to that a little bit?
Yeah, my understanding is that palliative care is covered under insurances. Generally, the providers end up billing under a palliative care counseling visit. And so if it's something that you're going to go into the clinic for, you usually schedule a time, with the goal of having a goals of care conversation with that palliative care provider and doing symptom management. Beyond the initial goals of care conversation, I'm not sure how it works. I know with Peace Health, we work through the foundation, and they do it through a philanthropic measure. And so Peace Health currently does not bill insurance in our outpatient program. The nurses and social workers that we have go out through the philanthropy.
Thank you. So if you think that your loved one is appropriate for either palliative care or hospice, what do? What are the steps? We start with you, Jennifer, or Julie, start with you for palliative care, and then we'll move on to Jennifer for hospice.
Sure. So it depends on how comfortable you are. If you're feeling really uncomfortable and it's something that you want to explore, we always recommend having that initial conversation with the primary care provider, or especially in the realm of dementia, it's usually either your primary care or neurologist that you're following with. for the individual. And so having that initial conversation with them, that you'd like to involve palliative care, that you'd like to start having more goals of care conversations about, you know, steps moving forward and what to be looking for. It's good to bring that up with them. My understanding in Peace Health's program is that we don't require a referral from another provider. You can self-refer to the program. I don't know how that works for Elder Place specifically, but really, you know, talking with your primary care or your specialist that's following for the dementia is the first step. And then certainly getting palliative care involved to help have some of those further goals of care conversations is that next step.
I think it's, I'm going to jump in now. I think Julie's done. I think it's very similar with hospice in that a great place to start off with is your primary care provider, but there's also other people in the community that can help you. You can actually call a hospice organization directly, such as Peace Health or Community Home Health, and they can kind of give you directions on where to start. Like Denny did a great job explaining, with hospice, you need a certificate of terminal illness, which takes place with probably 2 different providers on most occasion, and that's your primary care provider and the hospice director, whatever hospice program you're in. And they can talk you through it. I know with Southwest, we have a lot of support people that can talk with you. We have a bereavement center that starts involving the whole family right away, and then they follow that family not only when they're trying to make the decision if hospice is appropriate for the specific patient, but also it follows the whole entire family. So it starts off at the beginning and it goes all the way through and past when the patient has finally transitioned. So it's a great support system before, during, and after. So and like Denny said, it's covered through Medicare and provided in the home. So I think it's very similar getting on as palliative care, but then of course the actual outcome is a little different because it's done at home for the most part, but there's also different levels of care too. So we can talk about that later if we want to too, because hospice can become, or taking care of a patient can become overwhelming at times for people. So most hospice programs not only have like the starting, or talking to your PCP, which you can keep your PCP that you've had throughout your stay at hospice, and they work with us or work with the hospice team too, as well as our medical director, who's a doctor, and then the nurse practitioners like myself.
Thank you. So how long can you be on palliative care? Julie?
You can be on palliative care for years, years and years and years. So, in a perfect world, we would invite people onto palliative care the second they had a diagnosis. Unfortunately, we don't live in a perfect world. And so what we most commonly see is that we are interacting with individuals and their families in the last 1 to 2 years of their lives, when they have already identified that they have these chronic life-limiting illnesses and are starting to experience those symptoms that are suggestive of an end trajectory. And so, like I said, it could be many years. Dementia especially is very unpredictable in its pace. Some people advance quickly and then they stop advancing and they plateau for a while. And so it can be very challenging to accurately, educated guess at how much further they're going to go and what that time frame is like. But it can be many, many years that you spend with palliative care.
So Jennifer and Michael, this question is for you related to if there is not a specific dementia diagnosis that allows you to be on hospice. So what has to be wrong with you in order to be on hospice and have dementia?
Well, as far as, oh, sorry, Michael, did you want to take that one?
No, go ahead if you know.
I was just going to say, so dementia in itself is not a hospice diagnosis, but Alzheimer's is a hospice diagnosis, and so is brain ischemia. So there are a lot of different dementia type diagnoses that are allowed on hospice. It's just dementia itself. So I think that's it's kind of technical, but there. Whereas dementia is not a true diagnosis. There's other things that are very similar to dementia that make dementia a diagnosis. Does that make sense? Am I answering that correctly, or does that mean, yeah?
You can reframe dementia so that it fits as a dementia or hospice qualifying diagnosis.
That's exactly what I was saying.
Exactly.
Yeah.
Okay. And once you're on hospice, and I know that Denny touched on this, but how long can you be on hospice? What if my 6 months are up?
So once the 6 months are up, you do, well, technically you do a face-to-face, but I have patients that have been on hospice for 20 benefits period. So that's the first benefit period is 2 months, sorry, and then 2 months. Sorry, I might be confusing this, but you can go on and on past the 6 months. So 6 months and then 2 months, 2 months, 2 months. So it doesn't just end at 6 months. And there's people who are on it for 6 months, especially patients with dementia, and they do hit a plateau, or they actually possibly improve a little bit. So they go off of hospice, but then it can come back on hospice again when they get to, a level where they really do need hospice type care.
Okay. Anything different in your world, Michael?
Yes, very different. CMS makes rules both for hospice and for PACE programs. And the thing with us is our focus isn't on solely the end of life. It's to keep people out of nursing facilities. And so with us, it's sort of an internal decision to put someone onto our palliative care program. And because it's that internal, it doesn't change how CMS reimburses us. Whether someone is not on it or on it, it doesn't matter. And so for us, I've had people on our palliative care program for, as Jennifer says, years, not just for dementia, but just for whatever their medical plan is. If they've decided to be on our palliative care program, they're sort of saying, I'm focusing more on keeping my quality of life as good as it can get and to be as comfortable as I can be. I am not wanting to be rushed back to the hospital every time something goes on. See if we can manage this at home first. If something gets symptomatically is not controllable, then we can transfer back to the hospital. But for us, there isn't that on palliative care, off palliative care process. We have had people who improve and they say, I think I want to switch back. And then we switch them back, but it's their call, not ours.
Okay. So Denny, are there other services with hospice, such as music therapy or massage or other methods of symptom and pain management?
Yeah, that's one of the things I really love about hospice is, can you hear me okay?
It's a little quiet.
Okay, I clicked my unmute button, so hopefully you can hear me. One of the things I love about hospice is there's a lot of creativity in hospice care. And so, for example, hospice programs have pools of volunteers, for example, who love to do all kinds of things with patients. They can sit with patients, they can socialize, they can play bingo, they can read scripture, they can do music, they can go shopping for or with. They can do all kinds of things like that with patients, and we just really love our volunteers. We have some volunteers, for example, that play the harp in our care center in Salmon Creek. A couple of weeks ago, I had a volunteer that went out and dug up a couple of plants in a patient's yard and transplanted them. So just all kinds of things like that. I don't know, did that answer the question?
I think that was really helpful.
Okay.
So a clarification about cost. So if I have my loved one on palliative care and insurance doesn't pay for it, how am I going to afford it? Julie.
So within Peace Health's palliative care program, both in the inpatient and the outpatient setting, we have social workers as well, and are eternally grateful for them. Like I said before, with Peace Health, we work through the foundation, and palliative care is something that is not billed to the patient. If there are struggles beyond that, or it is a different program, most programs have access to, if not employees, social workers that can on ways to help with the financial aspect. But again, my understanding is that palliative care visits with your primary care and specialist are covered through most insurances.
Thank you. So Jennifer, I understand that Medicare pays for hospice, that's a hospice benefit, or that's a Medicare benefit. But what if we need to stay at one of the hospice houses? Do they take care of that as well?
There is different levels of care within hospice. So, and we're really fortunate at Peace Health. We have a great hospice house, and those nurses are dedicated to hospice patients closer to the end of their life. But that facility, and I don't want to jump the gun, but I think I should talk about the levels. So there's residential. That's where the patient is at home with their family, and the care is primarily the day-to-day care is primarily done with the family, but they get weekly visits from nurses and social workers and chaplains. And then there's something called respite care, which is the respite care is for the family, and this is all included in hospice benefits. So the respite care is when the family needs a break. And so for respite care, a patient can go into a facility such as the Ray Hickey House and spend a certain amount of days in a certain amount of period, and the patient will be cared for at Ray Hickey or at the hospice house, whatever hospice house that is for the organization. And the family just kind of takes a break, and they can go visit the family member at the hospice house. I'm speaking specifically about Ray Hickey because I don't know about all of them, but they can go in and visit. So that's kind of like a respite for the family. But then there's also, let's say the patient is on hospice and they have symptoms that can't be controlled with the medications that are provided for them in the house, which we provide a certain amount of medications for the most common symptoms at end of life. And if for some reason their dementia is turned, or they have agitation or something like that, they can actually be placed on what's called a general inpatient, and so they can come in and get that symptom out of control. They can get that out of control symptom in control, and we work very closely with those patients. So there's that too. It's not like they're on their own. They can come in, and we also have something called continuous care, And this is kind of the same thing as the GIP, and in which the patient, if they have some symptoms that are not controlled and the family's not able to help, or the visiting nurse, then they actually have a nurse that comes in and stays with them for about 8 hours every day and kind of helps with that symptom control without having to move the patient away from their home, because a lot of patients don't want to leave their home. Like, that's one of the main things. And I think Denny hit on it wonderfully. One of the best things, I think, for me is that the patient is taken care of in their home, and especially when it's that patient's and their family's choice to be taken care of at home. So there's a lot of different options, and Medicare covers all of those options. Once you sign in with hospice, everything is included for the most part. There are little nuances, but for the most part, all of that's covered.
So of all these levels that you describe, which ones are you responsible for the residential care, the expense of the residential care?
Yeah,
I'm at Ray Hickey.
At Ray Hickey.
Am I going to get billed for residential care?
I don't know technically the answer to that for everybody, but in general, that care is included in hospice care.
Okay. So Denny, is it different for communities, hospice house?
Nope, it's pretty much the same, just like Jennifer described. The actual CMS word for that level of care is routine home care. And so CMS's idea about that is that they consider that to be care that can reasonably be provided in a home setting. And so then theoretically it should be provided in the home. But we also have a 10-bed hospice care center in Salmon Creek. And we also do the general inpatient care that Jennifer described, and respite care as well. And I think it's just fantastic that Medicare considers the caregivers in this, in the respite care benefit, because it really takes a toll on caregivers, like she mentioned as well. So, but pretty much the same.
And that is 5 days quarterly?
What CMS says is the respite benefit can be provided on a regular basis. And then they allow each hospice provider or agency to define that. And at our agency, it used to be one respite stay every 3 months, but that's recently been changed to once a month. So that's a lot of respite stay. Now that's not always really in the best interest of the patient to be, bringing them on a stretcher, in medical transport into the care center and then back home again every single month like that. So it has to be considered in context, but that's what we allow and Medicare allows.
Thank you. So Michael, I'm going to ask you this question. Can someone with dementia make decisions about their care no matter what stage they're in?
No. It all depends on the stage. And that's where families are really helpful, and power of attorney designation comes in very handy. The problem is in America, we are very pro-choice as far as everyone gets to make a choice for themselves. Autonomy is our trump card. Unfortunately, with dementia, as it progresses, your ability to make an informed decision declines. What you need to be able to do as a patient, once the provider has explained to you, the benefits, the risks, your alternative options, you have to explain to them, oh, well, I want to remain on hospice, or I want to not have a resuscitation effort because, and then they have to sort of be able to lay out in their words why they made the decision. Is it a reasonable thing that they're saying? Now, reasonable is tricky because I might not agree with what someone says, reasonable, but it's reasonable to them. An example of this is there was a gentleman who had some chronic medical problems, heart disease, some kidney disease, and he was a do not resuscitate. Ended up having a stroke. So the do not resuscitate doesn't come into play here because his heart continued to beat. But now he's bedridden because the stroke took out a good portion of his function. And at that point, he changed his pulse form to a full code. And it didn't make a lot of sense because he's worse off now, but he wants to be full code. And until you saw the fact that his grandkids would come and visit him, and it was the greatest thing in his day, and as long as he could enjoy that, he had quality of life. And so for him, that meant it was worth fighting for that. Now it gets a little way because I didn't bring up dementia at all for him because he didn't have any. But even though a decision doesn't always make sense to us, if you can see the sense for the patient, then it's a reasonable decision. But they need to be able to say it in their own words so that you understand they know what they're saying. I mean, I've had people who say, no, I don't want to do this because, and then some crazy thing. And it's just like, okay, you're not getting the picture. You don't understand the consequences, the risks, the benefits. So they're not really able to make an informed decision. And as dementia progresses, that's the tricky line. So there's, they talk about capacity, which is a legal term, and us in the medical community love to say, no, we don't talk about capacity because, that's legal. But what we can talk about is capable to make a decision. And that's a day-to-day decision. And it sort of depends on the decision. All of us are capable of making a decision about, am I going to have ice cream tonight after dinner? And some of our demented patients will be able to make that decision too. They'll be able to choose which ice cream they want. But they're not able to understand the complexities of, do I want to be resuscitated? And so they're capable of one decision, but not capable of another decision.
Thank you. So, and because this is referring to hospice, Jennifer, I'm going to put it to you. Mom has dementia. She's frequently confused. One day she says she wants to be on hospice and the next she doesn't. What should I do?
Oh, that's a great question. I think it all comes down to, well, it doesn't all come down to anything, but I think a good conversation about goals of care and the definition of hospice would be a great thing to sit down, and there's people that can do that also with your mom. But I don't think that's an uncommon thing that happens. And I think it may be more a lack of understanding of hospice and what it does and what it doesn't do. I think we still have some negative feelings lingering about hospice. And I think when there's more people like Denny that talk, you understand just how all inclusive it is and how helpful it is. And I think it just comes down to conversations, open, honest conversations about goals of care with your loved one. And then that conversation might have to take place over and over again. And also I think just listening to the patient, not the patient, but your mother or father's, what they really want, and just listen. And I think that's a big part of it too. And let them know that that this isn't taking away from what they want. It's just adding to it.
Thank you. So Denny, what's your take on this one?
Yeah, that is a hard one. That does happen a lot. And I would say, avoid the H word, and just just say, hey, do you want to just be home, and just be comfortable, or do you want to still go to your doctor, or something that simple, because that's kind of what it boils down to. And then, I guess at some point you just have to, at some point the value of staying home and being comfortable outweighs the value of going back to the doctor, and that's the time to make the referral.
Thanks. So does Medicare pay for hospice even if you're not 65? Jennifer?
If you have a terminal illness, it does, yes. It's I think Medicare makes it seem like it's 65, but unfortunately we have patients on hospice of all ages, babies to 6-year-olds, so it covers everybody.
Okay. Does Denny, does insurance companies generally follow the Medicare guidelines when people are younger and they require hospice care? So insurance will pay for it?
Yes, they will. There are some insurances that do have a copay or a deductible, but the actual benefit that is provided, almost all of them that I've seen model the Medicare hospice benefit.
Okay, thank you. So you guys refer to CMS a fair amount. What's CMS? Michael?
I always get the acronym wrong, and it's a silly acronym because it's for Medicare and Medicaid services. I can't always remember what the C is. I said committee when I first started this, but it's not a committee. It's basically the government organization that sort of makes rules about Medicare and Medicaid. And so the Medicaid is obviously state by state, but there's still federal government subsidies and interactions and rules that they do push on to state Medicaids. And then Medicare is obviously federally funded and mandated.
Okay, thank you. We get so used to hearing CMS, it's hard to remember that everybody doesn't know what the heck you're talking about. I have more. I'm not done. Just a second. So how is COVID affecting hospice and palliative care and the way it's being provided? And I think I would direct that to all of you. You're all in a different setting. One at a time, maybe, since I have Michael's picture is up there. We'll start with you.
So with Elder Place, it's affected us in a strange way in that a lot of our people reside in facilities, either adult care homes or residential care facilities or intermediate care facilities. And so when a facility gets COVID, it just requires us to sort of decide, is this a virtual visit that I can make? Now with some of my folks with dementia, virtual is not going to work. It gets even tougher when I've got a translator involved or an interpreter, because that's just one more layer that my demented person has to try to figure out. So for us, it's mainly just more virtual visits to see people, or you're gowning up and putting on all the personal protective equipment in order to see somebody.
And how does that impact the person with dementia to see somebody in PPE?
Most of them seem to be doing okay with it. I mean, I think we've been in this for so long. I think they sort of realize, even though they're demented, they know that this is just some weird period we're going through where people wear masks and face shields and gowns and, stuff that we never did before. We always sort of apologize coming in that we have to do this, but that it's what the government tells us we have to do. But they, and the more demented you get really with this, I don't think it's just sort of, oh, here's the guy wearing this stuff. They don't the short-term memory parts are gone. So they don't remember that I wasn't wearing it last year.
Okay, okay, that makes sense. So Denny, how has it affected both your home hospice and your hospice house?
Well, we back early on, I think it was in February, Medicare or CMS, like we well defined, thank you for that, allowed telehealth visits. And so we're doing a lot more visits now by phone or by video calling, whereas before we had just gone personally to the home. And especially for the ancillary or supportive functions like mine, like social work, you know, the nurses really need to go. Well, sometimes nurses can do telehealth visits as well, but most of the time the nurses will need to go and actually personally see the patient. But for chaplains, for spiritual support, volunteers, and social work, we can often do a lot of it by phone with the family members and sometimes with the patients as well. But also, you know, in our care center, I think, you know, for us, it's just a matter of really communicating well about where the exposures are and, you know, where it's coming and where it's going to the best of our ability so that we can be protective and be wise about, you know, admissions and do the right thing and wear the proper PPE and so forth.
Okay, thanks. Jennifer, how has COVID changed life for hospice, both inpatient and outpatient?
So for patients with COVID in their own home, it's actually easier and nicer because they have family members they can be around. At the Ray Hickey House, the patients there are still allowed to have family members come visit. So it's limited, but they are allowed to have 2 family members per day, I think is what it is now. They used to be able to have more even before this last kind of upsurge of COVID. So I think that to me is the hardest or most difficult part is the patient, especially a patient with dementia who's in a facility. I don't think the masks or the gowns necessarily are a big problem. I think it's the fact that they have limited access to their family members, and it may be kind of like their last. It's the thing that keeps them the most comfortable is for their family members. So I think even the ability to do telehealth, not only as a provider, but for family members is really important. I think COVID has totally changed the face of, you know, everything really. And I think the population with dementia, it really has hit them really hard, mostly because of the lack of, you know, even in facilities, nurses are used to, I'm a nurse, we're used to going in and being with our patient and talking to our patient and touching our patient. And I think that in itself is probably the most difficult thing that's going on with COVID. But I think in general, the hospice environment recognizes the importance of being there in person. And so we've been trying everything possible to continue that, you know, as safely as possible. I do most of my visits via the, you know, Teams or Zoom because there's a nurse there with them. But I'm still at Ray Hickey. I still see patients. You know, I wear a mask, I'm very safe, and the patients are always very safe. And so it has made a huge impact, but I think everybody's just really trying to find ways to work with it. Yeah.
Okay, thank you. So Julie, as the palliative care practitioner in the hospital, I know that there have been some real challenges, especially because in-house palliative care tends to be hospice in the hospital. So
Yeah.
Can you tell us about that?
Sure. So one of the, one of the tougher things about inpatient palliative care is a lot of times we end up getting called because the question really is this person appropriate for hospice? Or the family is asking, we don't know where we're at, but we think maybe it's time. And so before COVID, we would have a family conference. We would have sometimes, I've had families as large as 15 people in a room surrounding a loved one to have a family conference about, where this person is at in their disease process, and is palliative care still helpful for them, or is it really time to just talk about focusing on comfort and looking at hospice as the appropriate service. Since COVID has started, the hospital has been forced to get pretty restrictive with visitors. And it comes and goes in waves. There was a time where we couldn't have any visitors. And certainly for a dementia patient to be in a strange place without being able to see someone who's familiar to them, that can lead into a delirium, which is always a major concern. We've gotten to a point where every person in the hospital at this point can have one designated visitor for the entirety of their stay. It's the same person the entire time, unless we're in an end-of-life situation where we are evaluating for hospice appropriateness, or if the patient has been transferred into hospice services while in the hospital, then they're allowed to have two designated visitors. But beyond that, we've had a lot more conversations by phone. It's more complicated the more layers you add to it, just like Dr. Valbuena was saying, especially when you have interpreters involved. We have a very large Eastern European group within Vancouver, and so we're oftentimes using interpreters. The preference is always, always, always to have an in-person interpreter because there are subtle nuances that are lost by phone. But we make the best efforts that we can to have who we can have. A lot of times it involves myself or our medical director calling our house supervisor and asking to have an interpreter in, special permission occasionally. But we do what we can to at least have that designated visitor there. We have also had our chaplains have come up with having tablets and doing essentially Zoom meetings so that families can see their loved one in the hospital and have a bigger face-to-face conference, even though they can't be there in person.
Thank you. So my last question for all of you is, what would you like our audience to know, assuming that people are attending because they have concerns about their loved ones who have dementia and are wondering at what point they would be appropriate for palliative care and hospice. So you're still up, Julie. We'll start with you.
Sure. I think the most important thing is twofold. First, it's never too early to ask the question, is it time for palliative care? And is it time for hospice? These are very appropriate questions in the dementia. Also, please know that not every provider that you're going to interact with is going to be comfortable with that goals of care conversation. And, I always tell my patients and their families, squeaky wheel gets the grease. And sometimes you have to ask that question multiple times. You really have to be the advocate for your family member. So those are my big takeaways.
Jennifer, how about you?
I think the biggest point for me would be that you don't have to do it alone or in a bubble, that there's people out there that can help you make these decisions. And there's people that you can talk to, and there's support groups. Taking care of somebody with dementia, no matter what stage they're in, it's a full-time job. And there's a lot of questions that people have when they're taking care of people with dementia. And it really truly does take a village. You have your family members and friends that you can talk to, but there's also professionals in the field that you can talk to and call and get questions answered. There's a lot of great organizations in Vancouver. There's more than one. And I think that the biggest takeaway is reach out and ask for help.
Thanks. So Denny, how about you?
I agree with what's been said. I think a lot of people say that they sign up for hospice too late, you know, and so and of course, like I said before, it is a journey, and so I don't know that there's a perfect, you know, I don't know that the perfect time to do it is the same for everyone, but I think most people don't say, oh, you know, I should have waited until, you know, the last minute to sign up for hospice. Most people say I should have signed up earlier so I could get the support at home sooner rather than later. And also, just to reiterate what Jennifer said, we go out to people's homes and provide explanations. You know, we don't and people should know that if they sign up for hospice, it's nothing they can't change their mind about. You know, a person can change their mind about hospice anytime and decide they want to go back for you know, medical intervention and care anytime they want to. So it's not written in stone. So thank you.
All right, thank you. Michael?
So for me, I think, as Jennifer said earlier, hospice and palliative care are sort of fighting some negative baggage that they bring with them. And I guess the thing I would like to leave you with is to try to forget that part of it. You know, Denny says no one ever, you know, regrets having joined hospice. It's that they joined too late. The decision to do hospice is different than the decision to do palliative care, just because of the rules involved with both. What you need to sort of realize is that it's, in America, we tend to think of fighting that good battle, and you know, someone dies, they lost their battle with cancer or whatever it was they had. You sort of need to refocus towards the end there on what kind of life do I want to lead for the last years of my life while I have these medical problems. Do I want to focus on my quality of life and try to maximize the good time I have with my friends and my family, and not necessarily, you know, crash the boards trying to extend my life for 3 more months with this new chemotherapy that, you know, is you know, going to make me feel terrible for those last 3 months. To really consider hospice and palliative care as an option to improve your quality of life, not as a way of giving up.
Thank you. So I think that pretty well covers what we have wanted to discuss this evening. And I want to thank our panelists for taking time out of their busy days. I think that each one of them came here directly from work, so we really owe them. This will actually be our last education for this year, but be on the lookout for a special holiday musical get-together via Zoom coming up soon on behalf of Hope, just for fun, just for all of you to be able to enjoy this season. So again, thanks to everyone.
Thank you so much. It's been a pleasure.
Thanks, Jennifer.